Otherwise, we will wait till the end and we will have a Q&A session at the end. But put your questions in the chat and we'll collect those and go over them. Also, keep in mind there will be an evaluation that'll come out after the presentation is done sometime in the next 24 hours. And we love your feedback. We really value the input and the recommendations for topics that you provide for us. So without further ado, I introduce to you Marty Ross.
Thank you, Shelley, and thank you, Shelley and Sarah, for the invitation to join you today. It seems the last 2 years have been everything COVID. So many projects and initiatives put on the shelf as we responded to the pandemic. And now we try and figure out together what the new normal is going to look like. But to get there, we will have to go through a very dangerous interchange of unwinding a number of the regulatory flexibilities, the payment expansion, other provisions put in place primarily by CMS and state law to assist providers through the pandemic and to continue access to care during the pandemic. So we'll talk about the unwind process as we go forward. We're also going to touch on the impact of Medicaid disenrollment. It is a topic that is not getting a great deal of attention, but holds the promise of having a very significant impact on providers as they'll see the number of the rate of uncompensated care likely grow with the end of the pandemic. And then finally, just talk about some of the issues associated with the Great Resignation, particularly the risk management issues that are now staring us in the face. Unfortunately, I cannot promise many solutions, but I can at least spot at the issues so we can appreciate together what we're looking for ahead of us. So let's start where we are in terms of the federal public health emergency. And why that's critical is so much of the authority that CMS exercised at the beginning of the pandemic, creating these regulatory flexibilities, these expansion of capacity, these waivers of regulatory requirements. All of that was tied to the declaration of the public health emergency, the national public health emergency for COVID-19. That occurred in March of 2020. It was actually retroactive back to January 1st of 2020. By law, the secretary has to renew any public health emergency declaration every 90 days. And we've had a series of renewals since March of 2020, the most recent being earlier this month. The secretary renewed the PHE through July 16. That doesn't mean the PHE will necessarily stay in place through July 16. It just means the next opportunity to renew it for 90 days will occur on July 16th. What HHS has promised is at least 60 days advance notice of the end of the PHE. So a lot of us have May 15 through 17 circled on our calendars because we would expect some announcement coming out of DC that the secretary will not renew the PHE and that we will officially go into unwind. Sort of an interesting development yesterday. Dr. Fauci, if I say it correctly, was interviewed on NPR, and he said that we are moving out of the pandemic phase of COVID-19 into the endemic phase. So interesting if that was potentially a first of many signals that the PHE will not be renewed going forward. We have had legislative attempts in Congress to end the PHE. Those have not been successful, but certainly the appetite to continue the status is certainly decreasing. One development we saw earlier this month, I think it was April 7, CMS published a notice that it was actually reversing or terminating a number of waivers that had been put in place early in the pandemic for skilled nursing facilities. If you'll recall, the President's State of the Union address, there was a particular focus on the safety of skilled nursing facilities, and the decision to terminate these waivers early were tied to enhancing safety regulation in skilled nursing facilities. So again, viewed as a signal that the PHE is not long for this world moving forward. So yes, it appears we are moving back to what the world looked like before all of these broad accommodations were made for providers. And probably out of all of them, the most significant is telehealth. I can remember where I was sitting the day that word came down that CMS was relaxing the coverage requirements for telehealth for purposes of ensuring that individuals could continue to receive care despite lockdown orders. So to start this conversation, we have to go back in time a bit and appreciate what Medicare coverage looked like for telehealth. Because before March of 2020, it was less than 0.1% of the money spent in Medicare was tied to telehealth. When Congress first created a telehealth benefit in the Medicare program in 2000, it placed a number of restrictions on the availability of these services. And that includes first and foremost the geographic restriction that CMS through Medicare only provides coverage for telehealth services for its beneficiaries who reside in rural areas. Secondly, Congress imposed a location restriction that at the time that rural resident is receiving telehealth services, they must be physically present at a facility as opposed to just being present in their home. Third, Congress directed CMS to generate a specific list of covered services. And if that is defined by CPT and HCPCS code. And so if your service isn't on the list, it's not going to be covered, even if the recipient of that service is a rural resident located at a facility at the time the service was being delivered. Fourth requirement was the providers who could bill for these services. Again, by statute, they're limited to physicians, non-physician practitioners, clinical psychologists, social workers, and registered dietitians, which excludes the obvious folks missing in that list are therapists, that they are not permitted to bill for telehealth services. And finally, the technology requirements that to be a telehealth covered service, it must be delivered with real-time audio and video capabilities that has real-time face-to-face interaction between the patient and the provider. So given that list of 5 restrictions, it's not surprising really that telehealth wasn't going anywhere in the Medicare program. And as you are all well familiar with the old line, as goes Medicare, so goes healthcare, that most, not all, but most healthcare policy is really generated in the form of Medicare coverage. And thus we did not see commercial payers running toward telehealth. There was broader coverage in state Medicaid programs, but still not to the level of what we saw after in March of 2020. Prior to the pandemic, we saw some movement in Congress to lift those geographic and location restrictions with respect to certain types of telehealth services. And these were very narrow categories, such as the use of telehealth to assist in an emergency department when a patient presents with stroke symptoms. Like for that is telestroke. You see here on the screen those other opportunities for expansion of telehealth, but again, very narrow lanes in terms of congressional approval of expanded telehealth coverage. Well, why, you ask? Was there concerns about the effectiveness of telehealth? The real reason we didn't see telehealth expansion pre-pandemic was the finances. Legislation that was introduced to expand coverage, to get rid of those one or more of those 5 requirements, would always be scored by the Congressional Budget Office by assuming that it was an expansion of a Medicare benefit, not that telehealth replaced a face-to-face service, but that in fact every telehealth service would be additive of the total cost of the Medicare program. And so each time the legislation is introduced, it gets hit with a very high price tag from CBO. And because of rules within the Medicare program that require, if Congress expands a Medicare benefit to a certain degree, it either has to raise taxes to cover that cost, or it has to cut other federal programs. And two things we don't see happen very often in Washington, D.C. are raising taxes and cutting programs. And so we really had sort of the steady state of where telehealth was going before the pandemic. But again, March 17th, 2020, CMS announced the expansion of telehealth coverage as was authorized by Congress through a series of COVID relief bills. And we had a series, all in all, by the end of 2020, a series of 4 interim final rules through which CMS continued to expand the telehealth benefit. That starts with suspending certain service requirements. CMS broadened out the list of covered services from 100 CPT HCPCS codes up to about 260 as it stands today. They eliminated, for certain types of services, they eliminated frequency requirements. They also permitted the use of telehealth as in place of face-to-face visits for certain type of supervision requirements as well. With regard to provider restrictions, CMS expanded out to allow therapists, speech language pathologists, physical therapists, occupational therapists, permitted them to deliver services via telehealth. They created a benefit for federally qualified health centers and rural health clinics to bill for services they deliver via telehealth. And they also created a benefit for the delivery of certain hospital outpatient department services and Method 1 critical access hospitals also to bill for services delivered via telehealth as opposed to face-to-face. CMS also loosened its requirement that a provider be licensed in the state in which the beneficiary receiving the services resides. It did not change state law. State laws were in place that require, as a matter of licensure, that an individual delivering telehealth services to a resident of the state is required to be licensed in that state. But what we saw at the beginning of the pandemic was CMS relaxes its rule as a matter of Medicare coverage. The states relaxed their licensure requirements, which allowed across state line telehealth without licensure in the patient's state. For the most part, those state allowances have expired. And so we're generally back to the rule that you have to be licensed in the state in which the patient resides today. But as a matter of Medicare coverage, that is not required. CMS also authorized payment for certain audio-only services. It created a new category of evaluation and management codes to allow providers to receive full reimbursement, even though they did not have the video connection with the patient. And finally, CMS agreed to reimburse telehealth at a higher rate. Before the pandemic, telehealth services were always reimbursed at the facility rate, meaning CMS would not pay the practice expense component of reimbursement for telehealth services. But again, to encourage adoption of telehealth during the pandemic, CMS announced that it would, in fact, reimburse at the higher facility rate, which includes the practice expense. So all sorts of accommodations coming down to increase the rate of telehealth coverage. In addition to what CMS provided, other agencies within HHS also gotten in the act. The Office of Civil Rights, which is responsible for HIPAA privacy and security rule enforcement, issued a notice of enforcement discretion stating that they would not impose any penalties for the use of telehealth, the delivery of telehealth services over non-public audio visual connectivity. So this is what allowed the use of Zoom and Teams for the delivery of telehealth services. The Office of Inspector General, that's responsible for the enforcement of the fraud and abuse laws, also came out with a notice of enforcement discretion, stating that it would not impose any penalties on a provider that waived co-insurance requirements for telehealth or virtual services during the pandemic. Then finally, the Drug Enforcement Administration, which has separate statutory authority, permitted the use of telehealth for in-person medical evaluations prior to prescribing controlled substances. So not surprisingly, with all of that in place, telehealth expanded rapidly during the pandemic. And we all did our best to figure out the technology, to figure out the scheduling, to manage the risks associated with delivering services via telehealth. And then moving into 2021, now in 2022, you've seen a gentle slope in a decreasing utilization of telehealth, but where you've continued to see the dominance of telehealth is in telebehavioral health services, as well as sort of routine primary care services. So sort of the sick visit, for example, those have continued to maintain at a higher level. It's the specialty services that took a relatively dramatic decline after the highest peaks in the first part of 2022. Everything I've said up to this point in time, as of December 1st, 2020, all was going to go away at the end of the PHE because of all the authority on which CMS and the other agencies were relying to provide this expanded telehealth coverage. All of that was tied to the declaration of a public health emergency. Since December 1st, 2020, Congress has acted in two ways to expand telehealth on a more permanent basis. The first of which was the Consolidated Appropriations Act of 2021, which is that monster piece of legislation that passed at the end of December of 2020. It has the distinction of being the single longest piece of legislation Congress has ever passed. And there were all sorts of programs tucked into that statutory text, part of which was the expansion of the permanent expansion of the Medicare benefit for telebehavioral health services. Congress acted to eliminate the geographic and location restrictions for diagnosis, evaluation, and whether the patient reside in an urban or rural area, regardless of whether they were present at a facility or at their home. So a significant expansion with regard to this particular type of service. And again, this is permanent. This will continue past the pandemic. They did place a condition on these telebehavioral health relationships that prior to initiating the telehealth relationship, there must be a face-to-face encounter between the practitioner or another practitioner in his or her practice and that patient within 12 months. Within 6 months. And then going forward, there needs to be a face-to-face visit every 12 months. Although in publishing the implementing regulations for this particular provision, CMS provided a number of exceptions that effectively, one of those cases of where the exception eats the rule. CMS has really minimized the impact of that 12-month requirement by allowing a physician to determine that it's unnecessary or potentially detrimental to the patient to require the face-to-face visit. In the regulations, CMS also allowed for the use of audio-only communication for telebehavioral health services, provided two conditions are present. First, the provider has to attest that in fact they have the capability to provide audio and visual connectivity for a patient. And secondly, that there is a reason, either a patient's determination or the provider's determination that a video connection is unnecessary. So that's where the regulations stand today. CMS last year published the implementing regulations, and this is where we will pick up or where we would have picked up at the end of the PHE. But then Congress acted again with the Consolidated Appropriations Act of 2022. This was the legislative package passed in March that continued funding the government through October of this year. Again, many provisions in that single piece of legislation, but that included the telehealth flexibility extensions. As you'd expect, there were a whole bunch of folks lobbying Congress to make permanent the telehealth expansions. Again, the price tag scared Congress off. You know, all these prior expansions of telehealth for purposes of the public health emergency were accomplished under an exception to PAYGO, so that Congress didn't have to offset the expansion of this benefit by either raising taxes or cutting programs, because all the COVID relief was done under PAYGO exception. So Congress, it didn't matter what it cost, and they just increased the deficit for purposes of expanding this Medicare benefit, excuse me. But wanting to provide some allowance for telehealth post-pandemic, and again, not willing to swallow the entire cost, Congress in the Telehealth Flexibility Extension Act agreed that for 151 days following the end of the public health emergency, it would leave in place the waiver of the geographic and location restrictions, the providing reimbursement for the therapists who deliver telehealth services, continue payment of those codes that allow audio only services, continue to allow federally qualified health centers and rural health clinics to bill for and receive payment for telehealth services, and then some other relatively minor adjustments that they made. So that's the good news, is that telehealth, we will have much more of a glide path out of the telehealth expansion post-pandemic, given this 151-day extension. And if you do the math, if the PHE should end on July 15th, it would effectively get us through the end of this year, that extension. So that's the one exception we have in place there. However, wow, what a busy slide, right? However, congressional action left a lot on the table. That there are many of those exceptions that were created for purposes of the pandemic that will end with the PHE. For example, at this point, we expect that reimbursement for telehealth will go back to the lower facility rate. So they'll no longer include in your reimbursement the practice expense component. There are still the use of telehealth in a number of circumstances for supervision purposes have not been extended. Frequency limitations have not been extended. And there remains a long list of services that currently are permitted by telehealth, which will go off the list at the end of the PHE. So there's a number of holes to be filled here. We are anticipating, with the publication of the 2023 proposed Medicare physician fee schedule, that CMS will fill in some of these holes. It is, for example, it's completely up to CMS and their discretion to determine the payment rate for telehealth services. So they could determine, as a matter of permanent policy, if they will pay for telehealth services at the rate at which the face-to-face services would be paid. So that is one example of where we may see some additional expansion of telehealth services. There are going to be, in very short order, a number of studies that CMS will be pursuing, or other entities will be pursuing, to look at the effectiveness of telehealth, utilization patterns, expenditures, and the like, for purposes of then congressional action to expand telehealth. This is targeted in part at that CBO policy of scoring telehealth as an expansion of services as opposed to a substitute for other services. So we're laying at least the groundwork for further action to expand the benefit. OIG is part of the mix as well to determine what enforcement action we potentially may see around telehealth. And then CMS will begin regularly publishing data in terms of utilization, beneficiary characteristics, types of services delivered for telehealth. One note here from a risk management standpoint, and I think this has been probably front of mind for an extended period of time, is the inherent risk of fraud and abuse within telehealth services, because it is not face-to-face. It's much harder to demonstrate a record for services that have been delivered via telehealth. So we anticipated that there would be enforcement action around these services, and where goes enforcement action tends to go private litigation. And some risk here, if we've expanded telehealth out as broadly as we have, are we going to see more litigation around failure to adhere to standards of care and the like? We haven't seen it yet, which I think is really interesting, because we've had an extended period of time now. We're more than 2 years into this, and yet, at least I have not seen any reported cases where the theory of the case is the service was improperly delivered telehealth, or the type of telehealth service was, in fact, not a true office visit. It was just a brief encounter. There's been some very limited fraud enforcement around some telehealth fraudsters, relatively minor, handled very quickly by U.S. attorneys, but just not the level of response we would have potentially anticipated from the use of telehealth at this level. Now it's a lot about Medicare, what's been going on in the commercial space. And this has been, I think, again, one of the more interesting outcomes of the pandemic is the number of states, including Washington State, that stepped in to the telehealth world by enacting parity laws. In Washington State, for example, effective last year, commercial payers, as well as Medicaid MCOs and government employee benefit plans, are required to provide coverage for telehealth services and to pay for those services at the same rate as the complementary in-person service, excuse me. Now, there's always a hole whenever the states step in to regulate health plans, because they cannot regulate ERISA plans. So self-funded plans are not subject to these rules. It's only the state regulated plans. There are also rules built into the Washington legislation that requires non-physician telehealth providers to complete certain best practice training as a condition of delivering services via telehealth. But there's about now, I think, 14 states that have enacted these full parity laws, parity in terms of both coverage and payment. Almost all states have some version of parity now, which requires coverage, though not necessarily payment at an equal rate. So this is one of those rare areas where the state legislators, in stepping in to regulate the business of insurance, have stepped ahead of where Medicare is in terms of ensuring coverage for telehealth services going forward. Again, interesting point here from a risk management perspective is this inclusion of this training requirement in the Washington State statute. Again, limited to non-physician telehealth providers, but certainly the creation of these training modules focus on best practices of how to perform telehealth certainly raises the bar as to what the expectation is, even for a physician that is using telehealth to deliver services. Are they in fact adhering to those best practices? So again, just to wrap up this topic, and I know we spent a lot of time on telehealth, but it's just been so incredibly impactful during the pandemic, and it has just so rapidly changed how we deliver medicine, how we as consumers receive services, that how it's going to unwind may be just as impactful as how it all started. But we'll continue to look at state licensure issues. That is, especially if you are receiving services from a larger national company. It's one thing when the local physician utilizes telehealth to remain in contact with his or her patients. But it's a very different story when you have a health system that contracts with a national provider to deliver a certain base level of primary care services. That is when you get folks from a centralized location delivering telehealth across 50 states. And that's where you run into licensure issues. And this is just a slam dunk. You know, it's either at the time they delivered the service, they were appropriately licensed in the state or not, but making sure as a matter of risk management and best practices, ensuring that there are processes and procedures in place to ensure proper licensure of telehealth providers. Going hand in hand with licensure always goes credentialing, and whether a facility requires anyone delivering telehealth to patients of that facility must be appropriately credentialed. And that issue, addressing it through medical staff offices and the like. Certainly, the privacy and security issues are going to be significant. We have lived under the enforcement discretion from OCR that have permitted uses of platforms like Zoom to deliver telehealth services. Certainly, Zoom has stepped up its security game. That's the good news. There is Zoom for healthcare, but we need to be careful that as we're using these different forms to deliver healthcare, have we looked at the risks around privacy and security, and appropriately mitigated as best we can through policy and the like. And then finally, I've touched on this before, the standard of care issue. Not just standard of care in terms of how do you conduct a telehealth visit, such as if you need to get a blood pressure, what are the accommodations made to secure that blood pressure from the patient? Just one of many examples. But there's also the issue of what services should be delivered via telehealth. When is it too far a stretch to rely on telehealth as opposed to a face-to-face visit? The answer in Medicare has always been easy because you just look down the list of services and you can always say, hey, CMS took a look at this and they determined this was appropriate for telehealth. But remember, that list that started at 100, expanded to 250, is going to go back down to about 130. As CMS retires certain services from coverage with the end of the pandemic, either immediately or by the end of next year. And so it's a matter of looking at how your organization is delivering telehealth, what types of services are being delivered telehealth, and whether in fact it's appropriate, or do you actually increase the risk by not delivering a face-to-face service. There's also the flip side of that, of course, is by not delivering services via telehealth and thus creating an access barrier. If a patient is not able to secure those services face-to-face, do you have a completely different issue at hand? So as goes forward, as the more healthcare changes, the more risk we find ourselves having to manage. So let's switch gears. Enough on telehealth. Certainly, though, it's going to be interesting times as we find our way out of those flexibilities. But in addition to what CMS and HHS did around the telehealth coverage expansion, they also expanded a number of flexibilities during the pandemic, relying on Section 1135 of the Social Security Act, which gives the Secretary authority to do both blanket waivers and individually directed waivers during public health emergencies. And appreciate, prior to COVID-19, our typical public health emergency was a tornado or an earthquake or a hurricane, and typically limited both in terms of geography and time. The fact this PHE has gone on for 2+ years is certainly out of the bounds of prior experience, and the fact that it was a nationwide PHE that effectively impacted every provider is also completely unique. And thus, these flexibilities have now been stretched as far as they have ever been stretched before. And now the question is going to happen is how will they snap back as we walk away from these endeavors? And I'll tell you, it is not a day is going by right now that we're not receiving inquiries from folks saying, we need to develop a plan for the unwind. How are we going to look at what we've done under the waivers and roll it back? And how do we account for what we've done before? Because after 2.5 years, it feels like normal how we've been operating under these waivers. The purpose of 1135 and its inclusion of the Social Security Act is an appreciation that in times of emergency, there have to be allowances made to expand providers' capacity. That for whatever reason during an emergency, you would expect that either due to the increased volume of demand for healthcare services or a provider unable to deliver services due to damage or other reasons, that you have to provide flexibility to expand the capacity of the existing healthcare infrastructure. The other reason for 1135 is to reduce regulatory burden. Again, if we have folks that if previously before the emergency, they were spending 80% of their time delivering patient care and 20% of their time complying with regulatory requirements, we want to lessen the burden, that 20% burden, so that now it's 95% of the effort to clinical care and 5% towards regulatory compliance. And so there are a number of provisions that historically have been waived as a matter of course during primarily disaster-related public health emergencies that were immediately implemented during the public health emergency. But over time, and again, across 4 interim final rules, CMS has either modified or waived over 200 federal regulatory requirements, some specific to certain types of providers, some across the entire spectrum of providers. In addition to that action at the federal level, HHS has also approved a number of changes and modifications to Medicaid state plans, which even though state declarations of emergency have expired, these approved changes to state Medicaid plans have remained in place unless the state has requested their termination, which has occurred in a handful of cases. So in addition to figuring out how we unwind for purposes of Medicare, there are also potentially state level issues related to expansion of the Medicaid state plan. How we go about preparing to unwind, and again, we're already beginning to see some of the forced unwind with the skilled nursing facilities. It's a matter of looking at both capacity and regulatory building. Again, the two reasons we have these Section 1115 waivers. With regard to capacity, we have to return all of our facilities to their pre-PHE operations. So any modifications that were made in response to surge capacity or to address patient quarantine needs, all of those are going to have to be reversed. So a number of hospitals, for example, began using different space within their facility for patient care areas that would not be in compliance with the Medicare conditions of participation. Or they have used different types of facilities. So they've entered into agreements with skilled nursing facilities to hold acute care patients. That would be how you have to unwind all of that and go back to what did our facility look like? How did it operate, on March 14th of 2020 versus how it now appears, and going back to that old standard operations. Critically important here are a number of waivers that allowed three-night stay in an inpatient facility prior to admission to a skilled nursing facility to allow for coverage. That rule, for example, was waived for the duration of the PHE. That will go back into effect. And that's going to have a significant impact on hospitals in terms of managing patients back to the 3-day stay, has an impact on skilled nursing facilities as they're going to see fewer patients coming in to their facilities because of the requirement of the 3-day stay coming back into effect. In addition to capacity, then there is the regulatory burden issues, returning to that old normal. The document you see on the right-hand side of your screen is sort of the running list that CMS has maintained in the form of an FAQ of all the different regulatory exceptions it has made. And this document kept growing and changing. It's been relatively steady since November of last year now, but it weighs in at 181 pages. And so this is the document we look to sort of as our guide as we talk to providers about the unwind process. Let's look at this, let's look at that. What have you done here? What have you done there? And again, they're far-ranging changes. And one example is the requirement for co-signing on a verbal order. That Medicare rules used to be very specific in terms of the time period in which that had to be completed. For purposes of the pandemic, CMS relaxed that rule. Again, after 2.5 years, what's become common practice now, we'll have to go back to the higher, more demanding standard that CMS has. So it is certainly a large task that one would want to initiate as soon as possible. And that first task is just figuring out what we do. what did we change? Where do we create allowances? What are our current practices across these areas? Because of course, failure to not go back to pandemic is going to create that risk for survey purposes, for purposes of other credentialing as well. Again, I've made a couple of references now to the discontinuation of SNF waivers. I'm only looking at this in terms of what CMS potentially can also do over the next several months, or next several weeks, excuse me, at this point, it's next several weeks. But they announced on April 7th that they were discontinuing certain waivers effective in 30 days, and another set of waivers, the discontinuation would be effective in 60 days. And in that case, it was the physical environment exceptions that they allowed the additional time with 60 days to unwind. My fingers are crossed that CMS will publish similar documents with respect to other providers, so that they do provide the laundry list of what is being decommissioned, so that would provide us some guidance as we prepare to unwind. Also, there's an issue of authority here, because under Section 1135, the Secretary's authority to waive is limited by the end of the public health emergency. So if absent any action in advance, the Secretary can't say, oh, in 30 days after the PHE declaration, these rules will go back in effect, because by statute, they will go back into effect the day after the end of the PHE. What we're hoping, maybe hope against hope, is that the Secretary does this as a matter of enforcement discretion, stating that although these rules now go back into effect, we will provide a grace period in which we will not pursue any enforcement action against providers, pending their action to unwind their reliance on the waivers. So stay tuned, I guess, is what I want to say here. More than anything, that CMS will hopefully provide some guidance for a step down process. Same with respect to states, that they'll be providing any guidance either related to their Medicaid program or any other exceptions that they provided. Finally, on this subject, our stock law waivers. This was another authority that the Congress had given the Secretary, which was to impose waivers of fraud and abuse laws, particularly the Stark law exceptions, that would permit certain financial arrangements between physicians and referral sources to buoy up physicians during the pandemic. You see here on the screen the 5 specific exceptions that were approved by HHS. A number of hospitals relied on these to afford either changes to physician compensation, changes to rental rates or lease rates, providing some low interest loans to keep practices afloat, to provide PPE to physician practices without charge. There's a whole range of different financial arrangements that hospitals pursued, again, just to buoy up their medical staff. Those, again, are also going to have to be unwound sooner rather than, as soon as possible, since most of these are often, agreements between the parties that document and memorialize these arrangements. We need to be paying careful attention there, because, as you know, there's one risk. There's the risk of being out of compliance with the condition of participation and the associated, corrective action plans and the like that are necessary to address those matters. It's a whole other story when you're talking about Stark violations, because of the very heavy penalties associated with those. These are going to require immediate attention within your organization if you took advantage of these waivers during the pandemic. Let's switch gears again. Doing okay here on time. We talk about Medicaid disenrollment. Again, this is just the potential impact on an organization as your patients lose coverage. So the short story of this is, during the pandemic, Congress said to provide relief to the states, we will increase the FMAP, the percentage of each Medicaid dollar that is spent, the percentage that's paid for by the federal government. We will up that in all states by 6.2%. So, for example, here in Kansas, our FMAP sits at 56%. So we have to come up with 44%, 44 cents for every dollar that's spent in Medicaid, and the government pays the other 56%. But during this period of time. That 56% went up to, I can't do the math off the top of my head, 50, 60 something, 62%. So less state money was being spent. The trade-off, there's always a trade-off in Medicaid. The trade-off was that CMS said, if you take our 6.2%, you cannot disenroll anyone from Medicaid during the PHE, unless the individual requests it, they move out of state, or they die. You keep everyone, once someone qualifies and gets on Medicaid, you do not do eligibility reviews for the duration of the public health emergency. And through everything that happened over the last 2.5 years, we've seen about a 19% increase nationwide in the Medicaid enrollment, particularly in Washington state. You've been a little bit below national average, about 18.6%. With the end of the PHE, states will have 12 months to return to normal eligibility and enrollment operations. That means they have to initiate renewals on all beneficiaries within 12 months and send renewal notices and requests for information to beneficiaries. If they do not receive a response that verifies eligibility, they have to disenroll that individual. Also, I mean, the state now has no longer receiving that additional FMAP. They have every incentive to get people off the rolls as soon as possible. Everyone is predicting this is going to result in a significant disruption of Medicaid coverage. CMS is trying to smooth that process by encouraging transitions to other forms of coverage, such as marketplace coverage, but no one sees that being a great solution. Instead, we expect there's going to be a significant increase in uncompensated care associated with that, disruptions in ongoing care and treatment as well. So once this will not be as immediate, it's not as if the day after the PHE is over, everyone's disenrolled, but it will be a relatively quick process that has to be completed within 12 months. And many states are beginning to plan now. Most states better be planning now in terms of how they plan to do that full-scale review within that 12-month period. Okay, last but not least, just a second. Let's talk about the impact of the Great Resignation. The numbers are jaw-dropping in terms of the impact that the pandemic had on the healthcare workforce. This is the most recent study I have found out of Mayo Clinic, which was a very broad national survey of healthcare workers that conducted between July and December of last year on attitudes and intentions going forward among the healthcare workforce. What they found in this survey is nothing that's going to surprise you. Just unbelievably high levels of burnout, concern about workload, fears of workplace safety, all of that driving folks to reconsider their continued participation in the healthcare workforce. And just the number that just sort of catches you off guard is just 40% of nurses state that they are likely to leave their current position within the next 24 months. 34% of nurses saying that they're likely to just reduce their workload to go back to part-time positions in the next few months. Nurses have the highest rate of leaving the marketplace, but physicians and non-physician practitioners are not far behind. The only place you really aren't seeing Great Resignation in healthcare is in more clerical positions or lower level MAs, phlebotomists, diagnostic techs and the like. Those numbers are not as significant, but it's the closer you were to the patient front line, the more likely you are to be feeling these effects. Interesting observation in this survey was that there was no correlation between the level of COVID infection in a region and the burnout effects. So it isn't necessarily that only in those areas that had high COVID infection rates are seeing these impacts of workforce stressor. It's uniform really across the nation. There are areas of the country that have some capacity to absorb the Great Resignation. There is actually in um, in the funnel, enough new students being trained, and new folks entering the marketplace, that they're going to be able to absorb some of this loss. If you go down to the Southeast, it's over. There's no capacity down there. There's just no available nursing staff. Physician shortage more severe. Actually, up in Washington State, you're probably one of the best positioned in terms of the potential new entrants into the market. But appreciate, we're dealing with the impact of COVID on top of an aging workforce, as well as an aging patient base that's going to be more and more demanding. So this is front and center. I mean, this is the issue we hear every single day: is workforce is what, and who's got, the silver bullet that can solve the workforce problem. The one, I don't know if it's a silver bullet, but it is certainly where the research is pointing you, is that there is a strong correlation between feeling disassociated with the organization and your likelihood to leave. Probably pretty obvious, right? But it also proves the opposite, is that if an individual feels more highly valued and connected to their organization, they are less likely to express this desire to reduce the number of hours or change positions. So the research is telling you you need to engage with these patients. It's not just not patients with your workforce, and it's not just a matter of increasing compensation. It's a matter of benefit packages. It's a matter of work flexibility. It's a matter of recognition. All of those are tying positively in this research to maintaining a more stable workforce. But the number of issues, risk management issues presented through both the issue of high levels of resignations, but also those who remain in their positions being burned out, are significant. Beginning with the increased labor costs and the pressure that places elsewhere on the budget. For providers, a lot of the sins of COVID were covered up by provider relief fund dollars, these federal dollars that they received to maintain operations and to cover lost revenue. Were filling in and meeting addressing lost revenue, increased costs. Those dollars are effectively gone. There aren't going to be any more payments coming out of the provider relief fund, just at the time that now every provider is facing higher labor costs and inflation, also increasing other costs as well, that there are going to be other cuts within the organization. And where do those cuts come from? And what's going to be the clinical impact of those cuts? And what potential risk issue, what matters of risk are going to be introduced as a result of that? You're dealing with issues of staff reassignment, moving patients into, moving staff into critical areas. So someone's got to cover the cath lab. But issues then are that staff adequately trained for these positions you're placing them in? Again, that's identified as one of the high stress levels that creates even more turnover, is that patients keep saying it wrong, sorry. Staff are being asked to move into a position with very little training. If they don't feel competent to do the job, they react negatively to the stress. And obviously, if the person's not appropriately trained, you also increase the risk that there be a clinical error that results from that as well. As you lose staff and even the ability to move staff around, then you get into the issue of your ability to maintain staff beds in a facility or outside the facility setting, maintaining current scheduling. So you're going to see a decreased capacity to deliver services, that financial impact that has, the clinical impact that has as well. Overall, the great resignation is going to be the long tail effect of COVID. We're going to be dealing with long COVID, of course, and the research there is also stunning. That something between the neighborhood of 10 and 35% of patients that had COVID will have long COVID symptoms. So everyone invests in respiratory therapists going forward. But this is going to be it's not going to be just the long COVID issues. It's going to be the loss of staff, the loss of capacity of seniority, and the negative impact that's going to have on quality care going forward. So I left a whole whopping 3 minutes at the end. I'm sorry, there's just a lot to cover as we start talking through these issues we're facing. So I guess we can open it for a few minutes of questions, and I'm happy to stick on a few extra minutes if necessary.
Thank you, Marty. That is absolutely amazing. I don't see any questions in the chat so far, so it sounds like everybody is digesting this information. And so I'm going to encourage people to just come off mute and initiate questions that might be coming to mind. I will continue to watch the chat feature in case you enter it there.
And plus, Shelley, you're going to share a copy of the PowerPoint with folks, right, that attended.
That is correct.
My email address is on the front. So if the question, strikes you tomorrow afternoon, please don't hesitate and shoot me an email, and we'll do what I can with it.
And as most of the participants know, this has been recorded, and so you will have an opportunity to listen to it again, and that might generate more questions. As expected, lots of great compliments coming through.
Thank you.
I think the take home, it sounded like, is find your nearest healthcare provider and give them gifts and accolades and as much recognition as possible if you'd like to keep them.
It's at least there's something positive in the research, right? It just, you keep reading through these reports and it's just like, they're all leaving, they're all dissatisfied, they all feel threatened. And it seems that it's the recognition component that's key. It's not necessarily paying them more, it's appreciating what they're doing and making their workplace safe and providing them with the training they need.
That's great. Well, rave reviews. It looks like people are logging off as their lunch hour is ending. So those that linger, if you want to indulge in a minute's worth of private session with Marty, here we have it. We've got time for it. Well, I think it is unanimous. This is just incredibly informative. I personally found that telehealth content just mind-blowing and enlightening, and really appreciate that. We get a lot of questions about that. So it's very helpful.
Great. Well, thanks again for the opportunity. And again, as questions come up, we'll do our best to field them for you.
Okay, sounds great. Thank you again for joining us. Thank you, everyone. Don't forget to complete your evaluation forms and stay tuned. You will receive these copies in your email soon.